Hi, good morning, everyone. How the Supernurse is doing?
Good morning.
Morning. How come everybody's so quiet? Still trying to open eyes? Is it a little too early?
No, I think we're all just up late studying.
Yeah, okay.
Good morning. I was still not able to check in. Could you please check me in? I didn't see any QR code. I tried to leave and come back and still no QR code.
Yeah, there. I think I verified, and many students checked in, so it could be. I don't know what's going on, but you guys were able to see, right?
Some of the students can, some of them can't.
Okay.
I'm not able to see it.
Yeah, I'm unable to see anything either. I don't know if you're showing something right now.
Yeah, half of us can see it, half of us can't. Not sure, but
Okay. So Bella, I checked you in. Let me.
are you guys using the Teams app or are you guys using the web browser?
Web browser.
I'm using the app.
I'm using that.
Mac.
Using the app.
And you guys can't see it through the app?
Yeah, I can't see it.
Okay, then it's not that.
Okay, so let me tell who is showing absent and let me know and I'll check you in, okay? Okay, Daniel? Daniel, are you here? No, okay.
Yeah, I'm here.
Shivana? Oh, you are?
Yeah.
Where are you?
I'm here. I just can't see anything either.
Okay. No worries. I'll check you in.
Thank you.
No worries. You're most welcome. All right, you are checked in, sir. And next, let me refresh my screens. Okay. Erica?
Here.
Here. All right. So I'll check you in. All right. You are in. Richard?
Yeah, I'm here.
Okay. Stephanie?
Yes, I'm here.
All right. Let me check you in as well. Okay. Then Siobhan?
Oh, I'm here as well.
All right. Siobhan, did you check my message?
Oh yeah, I just checked it. Yes.
You did?
Yes, I received it.
Okay. Okay, Valentina?
I'm here.
All right. Okay, and okay, looks like everybody is checked in. All good. So you don't see anything at all? Or some of you do see?
Now I see the code.
Yeah, I see it now as well.
No, I can see it now as well.
Works for me.
I don't, but I'm gonna come back.
Same. I'm gonna try again.
Yeah, I don't either. I'm gonna log out and log back in.
It just popped up for me.
Okay.
Sure,
Try
if you guys-
changing your views as well.
Hmm. Let me try to stop sharing and then share it back on as well, just in case, just in case. Okay.
Okay, now I can see.
Okay. But you probably don't see the full screen, right?
Or would you see
I can see the QR code.
Yeah, I see the
That's
QR
full
code
screen.
now.
See the QR code? Okay, how about now?
Yes.
Antidysrhythmics.
So do you see the it on the full screen?
Yes.
Yeah.
Just one complete slide, correct?
Yes.
Okay. All right, so any questions before we start, guys? No? Okay. So we'll be going over 3 chapters, similarly how we did yesterday. I received a message from a couple of you guys regarding your calculations. As I lost majority of the data I had, materials I had, so I'm working on it. Because the Fremont cohort, they had their final exam this week, and I have to schedule a session with them tomorrow, and I have to prepare the materials. So most likely by end of the week, end of the week, I'm gonna work creating more practice calculations for you guys, and as soon as I'm done, I'll share it with you. And then next week, I don't see any problem. I'll schedule a session. What day would be good for you guys for that additional session for calculations?
How long will the session be?
Depends how many problems we get, but somewhere from 1 to 2 hours.
Do you guys want to just extend it on a Monday or Tuesday? Or, like take a break and then come back, or?
I'd rather do it on a Friday before the test, probably. I don't,
I
but
think no.
You shouldn't go too close to the exam.
Because then I feel like if we do it close to the test, we're going to be overwhelmed and overstimulated. And then when we hit the test, it's like we're hyper focused on that.
You don't want to you know, have any clash while you should be studying for your exam. That's not ideal.
but this is studying for the exam now. I mean,
But
I'm
that's
fine with not
not
doing
the
Friday.
only
I'm just
thing.
saying that does. I
That's
understand.
not the only thing, because remember, everybody have different ways of studying, but I want to adopt something which would be beneficial for majority of you. And I know that when you go too close, when you should be focusing, I don't want to stress. That's not. I don't see that the right option. And it doesn't have to be just right after your class. I can look into options on Sundays, maybe in the evening as well. I can look into that. So you guys can discuss, come up with a couple of options and see what we can come up with. So what would be ideal? What do you think?
I'm open to any day and time, just not on our exam day.
Okay, for sure, yeah. So I want you guys to discuss among yourself and then figure that out. Let me know with a couple of options and we'll go from there. Okay? All right. All right. So the first chapter, anti-dysrhythmic. So we'll talk about, first of all, dysrhythmia, different type of dysrhythmia, and then anti-dysrhythmic, what type of drugs they are, and then which one is used for what, any adverse effect, interactions, and important aspects while developing a nursing care plan. So first of all, dysrhythmia. Dysrhythmia, any deflection. So somebody has a normal rhythm. Anything going left or right, what I mean by that is it can go in two directions, either slow or fast, correct? Slow or fast, and both are dysrhythmia. Make sense? Agree? Okay, guys, Darren, that let's do or whatever later on, and then let's put a break on that discussion. Let's focus on the material now. And arrhythmia means there's no rhythm, flat line. Okay, and the drugs used to treat and manage these abnormal heart rhythm, whether it's slow or fast, brady or tachy, both those drugs are your anti-dysrhythmic. Many of the drugs, they're simple, your hypertension drugs, like your beta blockers, calcium channel blockers. They're the same drug, just another indication. Okay, now when we talk about dysrhythmia, dysrhythmia is more like an umbrella term, a general term. And whenever there is any alteration, any deviation from the normal rhythm of the heart. Why does it happen? Whenever the electrical signals which regulate the heartbeat, they become disorganized, leads to irregular heart rate. Now, as I mentioned earlier, it could be slow, bradycardia, fast, tachycardia, and there's a third one, irregular, which can go either way. It can fluctuate. Okay, AFib is an example where the heartbeat is irregular, chaotic, can go up, down. Okay, and many things can cause that. It could be simple, just electrolyte imbalance, some structural changes to heart, ischemia, and even some medications can alter that. For example, somebody taking opioid, slow it down, right? Somebody taking stimulants, it will increase. Okay. Action potential. What is action potential? It's all about the electrical impulses. So action potential is a rapid change in the electrical potential across a cell membrane, which allows the conduction of electrical signals, okay, in the neurons and cardiac cells. In cardiac cells, the action potential are essential for coordinating the contractions that drive the heart's pumping action. Now there are several phases. For example, there's phase 0, 1, 2, 3, 4, and that action potential. As phase 0 is called depolarization. So when a rapid influx of sodium ions into the cell, that's what happens through the voltage-gated sodium channels, which results in a sharp rise in the membrane potential. This causes depolarization, muscle contraction. Phase 1 is the initial repolarization, which is a slight dip due to the efflux of the potassium ions. So that's early. Repolarization phase 2 is a plateau phase when the calcium channels open and then allows the calcium to enter into the cell while the potassium continue to leave. So this influx of calcium, it helps sustain the contraction, creates a plateau, which is important for allowing the coordinated contraction of the heart muscle. And in phase 3, which is the repolarization, then the calcium channel clogs, but potassium still exiting the cell, causing repolarization. And then the phase 4, which is a resting membrane potential, the cell returns to its baseline state, the normal state, maintained by the sodium-potassium pump, which keeps the inside of the cell negative compared to the outside. And then it prepares the cell for the next action potential. So it's a cyclic process. Okay, this is what I just shared, different phases. Now, look basic on this picture, okay? Now, on your EKG, you will see this P, then QRS complex, and then T wave. This is how the pattern should be. The P wave, that is the activation of the atrium. And then the QRX complex represents activation of the ventricles. And then T wave here, this is the recovery phase when ventricles are relaxing and filling. Okay, now a normal heartbeat, when you look like, if you calculate the number of boxes in between these peaks, okay, so the height, so every peak, before peak, it should be P, then QRS, and then T. Then once again, same repetition at the same interval. That's a regular rhythm. But when a heart is beating fast, tachycardia, then the distance or the number of boxes between peaks reduces. Okay, for example, if you calculate here 1, 2, 3, 4 boxes, there's like only 2 boxes. It's beating fast, more closer. On the other hand, when the heart is beating slow, the distance between one to another, the peaks, it extends. So for example, here, like 1, 2, 3, 4, 5, 6 boxes there. So that tells that the period is extended, heart is beating slow. And finally, irregular. It goes both ways, slow and fast. There's no consistent pattern that either going only slow or only fast. So EKG, electrocardiogram, this is the non-invasive diagnostic tool to record the electrical activity of the heart. It helps identifying if the heart's rhythm is normal or any abnormalities. So once again, P wave represents atrial depolarization, which leads to contraction of the atria. QRS complex represents ventricular depolarization, leading to ventricular contraction. T wave represents ventricular repolarization, when ventricles are relaxing. And then your P and R interval, which measure the time taken from electrical impulses to travel from atria to ventricles. And then your ST segment. This is between the QRS complex and the T wave, representing the period when the ventriculars are depolarized. And then you will also hear this term QT interval. QT interval represents the total time for ventricular depolarization and repolarization. I'm going to show you a quick video which will help you to understand how to read the EKG. It's a very simple, basic concept. So just focus on that, please.
What is going on? I'm checking in. Welcome to MITS, where we bring nursing to you. So today we're going to talk about the easiest way to do your EKG interpretation. So if you're a nursing student or a new nurse who wants to do your EKG faster, stick around. This video is for you. All right, guys, this is the 6-step EKG interpretation. So before we talk about the actual steps, we're going to discuss important concepts that will help us have a better understanding of what's going on inside the heart as it generates a heartbeat. The first concept that we are going to discuss is the conduction system of the heart. Now, the conduction system of the heart is pretty much these special cardiac cells right here that are responsible in conducting signals that cause the heart to contract. The first cell is called the SA node, right here, or the sinoatrial node. By its name, sinoatrial, this cell is found within the right atrium of the heart. This is also known as the natural pacemaker of the heart, because this is where the beginning of the conduction takes place. So from the SA node, the conduction goes to the AV node, or the atrioventricular node. By its name, this can be found within the border of the right atrium and the right ventricle. The AV node is also known as the gatekeeper of the heart. And the reason being is that it gets to decide whether what impulse to let through. So if the SA node generates
The sound stop for everybody?
Yeah, we cannot hear the
Yeah,
video.
the video stopped on my end.
Yeah, it's stop.
Professor, we can't hear the video. You're also on mute.
separate cells, one to the left and one to the right. And
Can you hear now?
Yeah, I think
Okay.
when you mute
Oh.
yourself, we can't hear the video.
Okay.
now they call the left and right bundle branches. And from the bundle branches, they will extend within the apex of the heart. They will be called the Purkinje fibers. So again, the conduction system of the heart begins at the SA node, goes to the AV node. Next is the bundle of His, the right and the left bundle branches, and then eventually Purkinje fibers. So another concept that we need to discuss will be the inherent rate of these cardiac cells. When you say inherent rates, these are pretty much the heart rate we generate depending on which cardiac cell sends an impulse. So for example, if the SA node starts it all and it goes all the way to the Purkinje fibers, this will generate a heart rate of 60 to 100 beats per minute. It starts from here, goes all the way to the Purkinje fibers, that will generate a heart rate of 60 to 100 beats per minute. However, for some reason, if the SA node fails or there's a block somewhere here, then the AV node will kick in. It will generate its own impulse. And when this happens, the AV node will generate a heart rate of 40 to 60 beats per minute. And that also includes the bundle of His. The bundle of His also will generate its own impulse, and it's enough to make 40 to 60 beats per minute. And if the AV node or the bundle of His fail, then the left and the right bundle branches and the Purkinje fibers will generate their own impulse, and they have the capacity to make a heartbeat up to 20 to 40 beats per minute. So now let us talk about EKG. It has different parts. We will start with a small bump right here called the P wave, followed by this tall structure right here called the QRS complex. And lastly, the last bump after the QRS complex would be the T wave. Let us discuss them one by one. Let's start off with P wave. The P wave represents atrial depolarization. During atrial depolarization, the two atria are contracted. Next up, the QRS complex. Now, the QRS complex represents ventricular depolarization. During ventricular depolarization, the ventricles of the heart are contracted. Depolarization is for contraction. So how would you know which one is which? That P wave is for atria, while QRS is to ventricles. So if you look at the diagram right here, the QRS complex, it kind of looks like an inverted V. So V for ventricles. So when you see a QRS complex, think about ventricular depolarization. So lastly, we have the T wave. The T wave represents ventricular depolarization. This is when the ventricles are relaxing. Keep in mind that every depolarization is always followed by repolarization. So for every contraction, will be followed by relaxation. That being said, the question is, where is atrial repolarization? So if QRS represents ventricular depolarization or contraction, and T wave represents ventricular repolarization or relaxation, then where is atrial repolarization if this is depolarization? Well, it can be found within the QRS complex. As you can see, the QRS complex, it's a tall structure. Because ventricles tend to contract stronger than the atria, they tend to mask the atrial repolarization. And so that being said, atrial repolarization and relaxation takes place after the P wave, which can be found within the QRS complex. Now, as a review, P wave stands for atrial depolarization. The QRS complex represents ventricular depolarization. The T wave represents ventricular repolarization, and the atrial repolarization is covered by the QRS complex. You can't see it, but it exists. So now let us talk about the segment intervals in the EKG diagram. There are a bunch, starting off with the PR interval, the PR segment, the QRS complex, the ST segment, and the QT interval. But to make it easy for you guys, we are just going to talk about the PR interval and the QRS complex. These are all we need to do the EKG interpretation. The other segments, they are important too, but we don't really need them to interpret the EKG faster and more efficient. So this is your typical EKG strip. In an EKG strip, we have a big box. And inside a big box, we have 5 small boxes. Each small boxes is equal to 0.04 seconds. And so if in a big box there are 5 small boxes, that means that one big box is equal to 0.20 seconds. But really, as long as you know that one small box is 0.04 seconds, we're good to go. So let us get on with our 6-step EKG interpretation. First up, we have to identify and examine the P waves, measure the PR interval, measure the QRS complex, identify the rhythm, determine the heart rate, and interpret your strip. And we're going to talk about them one by one. Let's start off with identify and examine your P waves right here. The normal P wave would be
present and upright. If the P wave is absent or inverted, then it could indicate a form of dysrhythmia, such as a junctional rhythm. Next up, we are going to measure the PR interval. PR interval is the distance between the beginning of the P wave and the beginning of the QRS complex. What we do is we count the number of small boxes in between and multiply it by 0.04 seconds. Our magic number for the PR interval is 0.12 to 0.20 seconds. Anything more than 0.20 seconds could indicate another dysrhythmia, such as heart rates. Third would be to measure the QRS complex. Just like the PR interval, we are going to measure the small boxes in between the QRS complex. Our magic number is 0.06 to 0.12 seconds. Anything more than 0.12 could indicate a dysrhythmia such as a PVC. Number 4 is we have to identify the rhythm of our strip. It could be regular or irregular. And the way we do this is we measure the distance between arms, R's and R's. Some people use calipers to do this, but really all you need is an index card. Mark your R's and march them with the rest of the R's. If they have the same distance, then your rhythm is regular. Otherwise, they are irregular. Fifth step is when we identify our heart rate. Now, before we calculate our heart rate, it is very important for us to know that our EKG is a 6-second strip. And the way we will know this is when we find these 3 lines right over here. If you see these lines, this means that from the first line up to the third line, that would be your 6-second strip. The reason why this is important is that if it is a 6-second strip, then we can do a technique called the 6-second method. And the way we do this is that we count the number of R's between these 3 lines right here and multiply them by 10. So for this strip, we have 1, 2, 3, 4, 5, 6, and multiply that by 10. That will give us a heart rate of 60 beats per minute. One thing to remember is that this method works best for irregular rhythms. And another tip that I can tell you is that you have to be very, very careful in using the 6-second method. You always have to verify that the strip that you're reading is indeed a 6-second strip. I know some teachers include strips that appear to be 6-second strips, but they're really not. We don't have these 3 lines right here. And students actually mess up the heart rate because they use the 6-second method. This method only works for 6-second strips. Okay. Second method that we can use to calculate the heart rate is the big box method. And the way this works is that we divide 300 with the number of big boxes between 2 R's. Our magic number is 300. So for this strip, we are going to use these 2 R's right here. So we have 1, 2, 3, 4, 5 big boxes in between R's. And so using the formula, 300 divided by 5, we have 60 beats per minute. This method works better for regular rhythms only. And this is actually the method that you can use if you don't have a 6-second strip in front of you. And the final step is interpret your strip.
So that is it for today, guys. I hope you find that helpful. And
Okay.
what's going on, guys?
Oops.
Welcome.
All right. So I hope give you some basic understanding about EKG. Are you guys able to learn something new? Yeah? Feel a little comfortable? It takes practice. It takes practice, but once you know what are the basics behind it, it becomes much more simple. I'm not going to give you any questions to calculate or, heart rate or rhythm or anything like that. But I always like to share it so that you know it, because I see students kind of running away from these strips when they go in clinicals. They have no idea what it is. So it's always good to learn. Okay. Let's move on. Now, common type, as I said, it's many different types of arrhythmia. Now, in order to help your patient to normalize their irregular heart rhythm, you need drugs called antidysrhythmic. Okay, it's the same thing. If you hear antiarrhythmic or antidysrhythmic, it's the same thing. They can be used to treat and prevent abnormal heart rhythm. So several classes. For example, your sodium channel blockers. Okay, sodium channel blockers. Now, class 1, your sodium channel blocker, they're further divided into class, like, 1, 2, 3, or and in one itself, it's 1A, 1B, 1C. Now, I'm going to show you a mnemonic and a picture on the next slide. I want you to memorize that. If you don't like that mnemonic, create your own. But that will help you to identify which one belongs to what class. Okay, but antidysrhythmic. Not necessarily that you'll be tested on all kind of drugs and which one belongs to what, maybe here and there, but that will help you to memorize them in the long run. Okay. Let me actually show you that so that you guys can see it while I'm talking. Okay. For example, here, and there's one class missing here. If you see, there is 1A, 1B, 1C, and then 3 and 4. 2 is missing. So class 2 are the beta blockers, the drugs ending with LOL, which we were talking yesterday. So class 1, further subdivided into 3, 1A, 1B, 1C. So 1A starts with PDQ. PDQ, P for prokinamide, D for disopyramide, Q for quinidine. And then 1B, LM. L for lidocaine, M for maxilitine. And then 1C is FP, flecainide, propafenol. And then class 2, they are beta blockers, ending with LOL. Okay. And then class 3, those are your potassium channel blockers. They're potassium channel blockers. So AD, SD, okay, or ADSID, sorry. So A is amiodarone, dronadrone, sotalol, ibutylide, and difetilide. Then your class 4, these are your calcium channel blocker, CCBs. Remember 2 of them which do not end with the same suffix how all others in the same class. Those are diltiazem and rapamycin. Okay. I'm going to talk about them one by one, but this slide will help you to remember. Okay. Now these drugs might be categorized, classified, where they act and how they act on different places. Now, if you look up, once again, class 1, they are your sodium channel blockers. They inhibit the sodium channel, reducing the speed of electrical conduction in the heart. Okay. And once again, how to remember them? 1A, 1B, 1C, and 1A PDQ. So the drugs belong to this class 1A are prokinamide, quinidine, disopyramide. Okay. So if somebody asks you how do they work, well, they're sodium channel blockers. They block the fast sodium channels, leading to a decrease in depolarization, which is phase 0. They also block the potassium channel, prolongs the repolarization. Then these are mostly used for AFib, A flutter, AFib, the heart is beating really fast. Also for your ventricular tachycardia. Let's go over a few important aspects. For example, your prokinamide. Know that PDQ belongs to 1A. Important to know is what it's used for. Atrial and ventricular tachydysrhythmias, when heart is beating too fast. When heart is beating too fast. Another important thing to know about this drug is adverse effect, which is QT prolongation. The interval between Q and T that extends means can slow down the heart. That is a potential adverse effect. As far as quinidine, it's once again from 1A. This is driven from cinchona alkaloids, and a potential adverse effect, it's called synchronism. Synchronism means the patient usually have issues with their vision and hearing, tinnitus, okay? Loss of hearing or blurry vision. This is a common thing. Not common, that something severe can happen with this drug. In class 1B, phenytoin and lidocaine. Now, here we're talking about these sodium channel blockers. Lidocaine only for ventricular dysrhythmias. Phenytoin comes with a lot of adverse effects. So we need to know those. So first, let's talk about the lidocaine. So lidocaine, important to know. You need to have a healthy liver to metabolize lidocaine. Healthy liver. Now, what if the patient does not have fully functional, healthy liver? It can still be given, but you need to reduce the dose at least by 50%. So that's important for us to know, that if somebody's given lidocaine and they don't have 100% healthy liver, make sure you reduce the dose by 50%. For example, somebody has liver cirrhosis and that kind of stuff. And toxic doses can cause convulsions. That's what is important about lidocaine. Then your flecainide and propafenone, once again, these are sodium channel blockers, belong to 1C. You don't have to go much deeper in this. Okay, now your class 2. Class 2 was missing on that slide. They are your beta blockers, which ends with LOL. As the name says, beta blockers, they block beta receptors. Which one, beta 1 or beta 2? Beta 1, because we're talking about the heart here. Right? Now, do you remember yesterday what we're discussing? Like which patients or what conditions we should be careful about with beta blockers? There are a few things. Remember the antihypertensive medication yesterday? What do you remember about beta blockers?
Respiratory
Was that
depression.
because
I was gonna say they could go to the lungs too.
Yeah, go ahead. Yeah, you're on the right track.
Oh, that was kind of all I got, but they could go to the lungs and cause issues if you have like asthma or COPD.
Respiration, depression.
Yes, so asthma COPD patient, because it can cause bronchoconstriction, correct? So that's a concern. What else do you remember? Yes, Angie, good. Diabetes. What was the problem with diabetes patients?
Mask the symptoms.
Yeah.
Of hypoglycemia.
Good job. Good, Amy and Kelly. Yes. Mask the symptoms of hypoglycemia. So that's what we should be aware about. Now moving to class 3. Okay. Amiodarone, Dronadron, difetilide, sotalide, acetalol, and the butylide. So these drugs prolong the repolarization in phase 3. These are used to manage more stubborn dysrhythmias. Okay. Important. Amiodarone is an important drug, or brand name Cordaron. Amiodarone. What is important to know? Amiodarone is the drug of choice for ventricular dysrhythmia. It's also called ventricular tachycardia, or for AFib or flutter. That's very important to know. Okay. Amiodarone is the drug of choice for ventricular dysrhythmia. If somebody asks you, how does it work? Well, it prolongs the action potential. And if you remember, action potential is a rapid rise and then subsequent fall in the voltage, membrane potential across a cellular membrane. Okay. That's pretty much it about this medication, but whatever is here, it is important. Nothing much about the butylide. Okay, class 4. These are your calcium channel blockers, CCBs. And remember, I told you 2 drugs, diltiazem, verapamil. Diltiazem, verapamil. Those are the ones we need to know. For example, diltiazem here. What is important? Important to remember what is highlighted here. The what is used for. Diltiazem, it is indicated for a temporary control of rapid ventricular response. Rapid ventricular response in a patient who has AFib or flutter, atrial fibrillation or flutter, and also for paroxysmal supraventricular tachycardia, also called as PSVT. That is what important to know. That's a drug of choice for temporary control of rapid ventricular response in patients who are experiencing AFib or flutter or PSVT, paroxysmal supraventricular tachycardia. Okay. Nothing else. Everything else is not that important. Okay. All right. Now, there are few more which are not listed under any of the classes we just talked about, such as adenosine. Adenosine has an extremely short half-life, only about 10 seconds. So this is what is important about this drug. Number 1, which I just mentioned, it has a short half-life of 10 seconds. For that reason, it's given as an IV push. As an IV push. Second important thing, and that's very important to know because you may freak out if you are looking at the screen. The reason is, okay, what happens when your computer starts lagging, right? It's kind of processing. What do?
You restart it.
You reboot it, restart it, right? You press the button, there you go. You're shutting you down, and then once you turn it back on, usually it starts behaving better, right? That's what happens. Similarly, this drug adenosine, that's what it does to the heart rhythm. It resets the heart rhythm. So when you're resetting, what happens? Your computer turns off, right? Computer turns off and turn back on. So similarly, for just few seconds, you will see a flat line. Okay, just I would say maybe 3-4 seconds. That's it. That is a reset button for the heart rhythm, and then usually comes back the normal rhythm. So don't freak out if you see the flat line. Oh my goodness, did I kill this patient? What did I get? Okay, if you don't know that, well, that's the first thing you're gonna look. Oh my goodness, flat line means boom, gone, right? So it's just a temporary flat line, and then it should come back. Right? Everybody is comfortable? Any issues, any problems, any concerns, any questions?
No questions.
Right, all right, all right. Let me just look at everybody, that everybody's awake. All right. Nursing implications. This is always like, related to patient's problem. Look at the problem, where we started, what interventions, and then how it's affecting, how the patient is responding. And in order to compare something, you have to have a baseline. So always have baseline set, vital signs, all that assessment part, which includes any history, previous experiences, what they eat, what they drink, other medication conditions, whatever you can add that, and now utilize that to compare with the current scenario. Okay. And whenever you're dealing with heart, make sure you monitor rhythm, blood pressure, heart rate, and then intake, output, daily weight. These are very common things which you should be focusing on. We just talked about it, what to monitor. Now, these medications are important to keep your patients safe. Educate them the importance of adherence, the medication adherence, that they should not skip the medication, not abruptly stop them, do not double dose, take them as scheduled, as prescribed. And if it's not an immediate release means it is not a modified dosage form like a controlled sustained release form, then only can be taken crushed. But any modified dosage form, sustained, controlled, all those with the coatings, they should never be chewed or crushed. Okay. Monitor patient's EKG. Look at the QT interval, because many drugs can extend that, and that will slow down their heart rhythm. So that is also not a good thing. So keep an eye on that. Always assess the patient any relevant symptoms which can indicate issues with the heart, such as shortness of breath. Remember, yesterday we were talking about left-sided heart failure causes symptoms in another L, lungs, and that can cause shortness of breath. Right-sided heart failure can back up fluids in other parts of the body, such as edema, right? Somebody's having chest pain, blurry vision, edema, all those things you should be able to identify at an early point. Always, these drugs, before you give them, take a pulse for full 1 minute. And what the super nurse is gonna do, if it is below 60, we are gonna do what? Hold the dose and call the DOCTOR, right? Doctor, that's what we're gonna do. Okay. This is pretty much the same thing. Okay, let's see. Excuse me. Okay, good job, guys. Yes. D is the correct choice. Lidocaine, which is a sodium channel blocker, it is used to treat ventricular dysrhythmia. Okay, good. All right. Excuse me. Okay, great. Yes, B is the correct choice. Should be given rapidly as an IV push because its half-life is real short, 10 seconds. 10 seconds. Okay. This we can skip that. Okay. All right. Any question from this chapter before we take a break? Anything? No?
Professor, there is a noise. I don't know if
That's from Carly's end. That's whenever there's something I see, I hear that. Carly, I don't know what is going on. Okay, there you go. I had to mute. I don't know what causes that. Oh, she's trying something. All right, all right, all right. Any question, guys? No? Daniel, I'm causing headache. He's like, yeah, for sure. All right. I'm sorry. I wish I had something gentle to pass on, something gentle, soft music, but pharmacology is a little harsh. Okay, so my apologies. All right. Okay, you ready for a break? Yeah. It's 10:02. Let's come back at 10:15. Okay.
Thank you.
Thank you. I'll see you soon. Okay, can you guys see the screen again? Yes. The full screen?
I can see
Yeah.
the coagulation modifier drugs.
Okay, perfect. Yeah, because earlier I think I know what happened. I didn't share the sound. So I just wanted to share that again.
Now they can't hear me. I wonder.
What happened? Is it Carly or who's talking? All right. Let's move on to our next chapter, coagulation modifiers. Because there are many subclasses, that's why we're using the umbrella term of coagulation modifiers, not just simply anticoagulants. So talk about different problems, different type of drugs, indication, interaction, adverse effect, kind of good and bad stuff, and important aspects when you're working on a nursing care plan or helping a patient who might be taking one of those drugs. All right. Some of you have cameras still off. Please turn them on. Okay. Let me ask one thing I almost forgot. Did anybody ever ask about class representatives? Have you ever been asked about that?
No, we have not.
Okay. So if you could please discuss among yourself and then, share with me the names you guys proposing or whoever is interested. And then what I can do is next week I'll run a poll and you guys can vote and select 2 class representatives. Okay? Yes? No?
Okay.
Wake up, wake up, wake up, wake up, wake up. Look, when you guys it's so quiet, I feel sleepy. Now I'm slow, sleepy, drowsy, dry, like took Benadryl, antihistamine.
I think it's just because everybody's nodding their heads, so that's why.
Okay. All right, guys. So we'll do that next week. Let's move on. There are a few terms good to know. First, hemostasis. Hemostasis. Heme means blood. Stasis means something stationary. What that means is the process by which the body stops the bleeding after injury. Hemostasis, stopping the blood. Everybody clear about that term? Okay. Now, there are a few steps while this happens or the body does. For example, vascular spasm, immediate vasoconstriction of the blood vessels to reduce the blood flow and minimize the bleeding. Then platelet plaque formation. The platelets, they're there to expose collagen of the damaged vessel, becomes activated and aggregate to form a temporary plug. Then coagulation, activation of the coagulation cascade, which leads to conversion of fibrinogen to fibrin and forms a stable clot. Next is clot retraction and repair. The clot contracts to reduce its size and facilitate wound healing. And then clot dissolution called fibrinolysis. The clot is gradually broken down after the vessel is repaired to restore the normal blood flow. See how magically this body works. Forms a clot, dissolve its own. So fascinating. Now, a couple other things here. Thrombus. Thrombus simply means a blood clot. Okay. Now that formed blood clot, when it decides to go on a walk, okay? And just open eyes and say, I'm gonna go on walk. That moving blood clot, which we just called as thrombus, its name becomes embolus, moving clot in the blood vessels. Okay, everybody understand that part? Any question? Thrombus is a formed clot. In that clot, when it starts wandering around, that is called embolus. And based on wherever it decides to take a break or settle down, could be named based on that and the conditions associated based on the location. For example, if it decides to go downwards in the leg, it causes deep vein thrombosis. It goes the journey towards the lungs, pulmonary embolism, right? Decides to go explore the brain area, cause stroke, right? Heart, MI, myocardial infarction, heart attack. Okay. So this is your hemostasis, the process we just talked about, the process of stopping the bleeding after an injury. Okay. Now, embolus, as I just mentioned, is a moving clot, travels through the bloodstream and can cause an obstruction in a blood vessel. Now, it has what? A thrombus, a blood clot, may accompanied by fat air. And when this embolus, the moving clot, lodges in blood vessel, it can block the blood flow further down right from there, and then leading to the tissue damage because now it is restricting the blood supply with oxygen to the area further down the road, right? So not enough oxygenated blood supply, and they are deprived and it starts dying. Okay, so as I said earlier, based on the location, pulmonary embolus or emboli, blood clot which travels to the lungs, causing respiratory issues. Arterial embolus, which blocks an artery, possibly like a stroke if it goes to the brain. Fat embolus. This usually happens when, in more commonly in older patients when they have fractures of bones, long bones, where the fat particles from the bone marrow enters the bloodstream. And then there's air embolus, when air bubbles that enter the circulation, which usually because of a trauma or during a medical procedure. And whenever there's an embolus, a moving clot, that is a medical emergency, requires immediate intervention. The reason, they block further supply of oxygenated blood, the tissue will start dying. We need to open that channel and restore the blood supply, correct? It's like simple like a water hose, right? That you wanted to supply water at the other end, but there's obstruction in between. In order to restore the supply, you need to unclog that, remove that. So there are two ways, right? Either you dissolve it or you take it out. That's why these two different methods are used, either to dissolve it or to take it out. And there are drugs they call like artiplase, retiplase, tenecteplase. So they usually have two types of time windows. They call them the first time of contact to the needle time, or they say like, entry or the door to the needle time, like, the first time anybody gets in contact, like the emergency crew, or they calculate from the time they enter the facility, then it's more effective. Otherwise, they have to go with alternate approaches. Okay, I'm going to show you a video here. I'm not going to play all because there are 3 or 4 videos which are lengthy. Will take quite a bit of time, but I want you guys to watch it later today. That'll give you more clarity, understanding about this clotting process.
Hi, in this video, I'm going to talk about...
Can you hear it? Okay.
Yeah.
Hemostasis. In particular, I'm going to talk about the formation of clots, thrombi, and antiplatelet drugs. Now, first of all, I want to make a couple of definitions. The first one is a clot. Now, a clot is good. A clot stops bleeding. For instance, when you injure yourself, you clot and stop bleeding. A thrombus, on the other hand, is bad. It's also a clot, but it happens within a blood vessel, so it actually blocks the vessels. So let's look at how this happens. I'll draw out a blood vessel here. And in this blood vessel, of course, we'll have some red blood cells. Now, this is a bit of damage to the endothelium. The endothelial cells are the cells that make up the blood vessel walls. So if you get some damage to those, for instance, a break within the vessel wall, then you'll get a bit of collagen exposed here. Collagen is a protein which is integral to the structure of vessel walls. Now, when you have some collagen exposed like this, you get platelets sticking to it. And these are little platelets, they're just floating around in the blood. And they start to stick to it like this. Now, when that happens, the platelets get activated and they release a chemical out into the bloodstream, which calls on more platelets. This chemical is called thromboxane A2. You may have heard of this before in the arachidonic acid pathway. If you haven't, have a look at the video on arachidonic acid and icosanoids on handwritten tutorials. Now, this calls more platelets onto the scene. Then, on top of the platelets, we get a bunch of proteins called fibrin. And they're basically big fibrous strands that help make the blood clot, and they stick the platelets together. Then this fibrin will trap a couple of red blood cells in it. And then on top of that, you'll get even more fibrin deposited. And then this process kind of repeats, and this is what causes a clot or a thrombus. Now, this whole process can be avoided if you stop the thromboxane production by platelets. And this is done with a COX inhibitor or a cyclooxygenase inhibitor. Again, have a look at the arachidonic acid and icosanoids tutorial on handwrittentutorials.com for more information. An example of a COX inhibitor is aspirin, and that blocks the thromboxane A2 production. And this means that the platelets won't stick together and the clot won't be formed. In this way, you can actually stop thrombi forming, but a side effect is that you can also get excessive bleeding. And that's an overview of clots, thrombi, and antiplatelets. We'll have a look at how the production of fibrin is controlled in the next tutorial.
Okay, so the other videos, if you could watch after the lecture, that will help you all these steps of hemostasis and the coagulation, all that will help you to understand things a little better. Now, as far as the coagulation system, it is a complex network or process which works to form a blood clot after an injury in order to stop bleeding, and that is called hemostasis. And there are different proteins, enzymes involved, which are called clotting factors. Okay, and the way they work, it's called a cascade. Like one stimulates the other, and the other, and the other, so it forms a chain reaction. There are three main pathways involved in that. One is intrinsic, others extrinsic, and then the common pathway. So intrinsic is called the contact activation pathway, when it activated when blood comes into contact with the damaged vessel surface. So it involves multiple clotting factors, such as your factor 12, which leads to the activation of factor 10. And one of the videos shows you stepwise approach, like how it gets activated. So this pathway kind of amplifies the clotting response. Extrinsic pathway, which is a tissue factor pathway, triggers by trauma to the vessel and exposing the TF, called the tissue factor, which then interacts with factor 7. So this is the initial response to injury, leads to activation of factor 10, ultimately converging with the intrinsic pathway. Excuse me. Common factor, that's factor 10, from both the intrinsic as well as the extrinsic pathway, converting prothrombin to thrombin. And then the thrombin converts fibrinogen into fibrin, which forms a mesh-like structure to stabilize the platelet, the plug which was formed, and then forms a blood clot. And then thrombin also activates factor 13, which helps cross-link the fibrin strands, creating even more stable clot. Okay. This is what we just talked about previously, but this is fibrinolytic system. Lysis means breaking down. Okay, so this initiates the breakdown of clots. So in patients who are at risk of clots, breaking down the clots, fibrin, once they're no longer needed in natural way. And similarly, the drugs can play the same role. This help maintain the balance between the clot formation and the removal, so that it doesn't cause some sort of blockage into the blood vessels later on. What is involved here is plasminogen, which is a precursor protein which circulates in the blood in an inactive form. And when there's a clot formation because of an injury, it just starts walking along. It gets stick to the surface of the clot, so that when the right time comes, it dissolves the clot. And then plasminogen activators, they convert plasminogen into plasmin, which is an active enzyme useful in degrading the fibrin. And then TPA, tissue plasminogen activator, and then UPA, which is urokinase plasminogen activator. These are the two main activators. And TPA is primarily released by the endothelial cells, a most important activator in the breakdown of fibrin in the clot. Plasmin is the active enzyme which digests the fibrin into smaller pieces, fragments, which is known as fibrin degradation products. This is useful, helpful to restore the normal blood flow. Okay. This we just talked about. Okay. A little bit about this condition, a rare genetic disorder, hemophilia. Now, as we were talking about earlier, whenever injury happens, all that system in the body activates and help to plug that blood vessel wherever the injury is, forming a clot. In patients with hemophilia, they are deficient in clotting factors. So there's a hemophilia A, hemophilia B. In hemophilia A, the patients are deficient in factor 8. In hemophilia B, they're deficient in factor 9. Now, both of them, both types, result in prolonged bleeding after injuries, surgeries, so they're at high risk. These patients need, replacement therapy because they're missing clotting factor. So if they ever have an injury, they need a replacement factor to stop the bleeding. So as here, normal blood vessel, when it's injured, bleeding starts, but it gets clogged or plugged with help of a fibrin, a clot formed by the clotting factors, which are important in that process to form a clot. But these patients, hemophilia, they're deficient. They don't have those factors, and then they keep bleeding. You have to educate these patients, even that, hey, even in your house, walk carefully. Don't hit the corners or, furniture and all that. This is high risk things for them. They get bruised real quick and they can bleed severely. So now, in one of the videos, you will see these steps, okay, how these factors works and how these drugs produce its effect at what point. Okay, this is the coagulation cascade, a series of biochemical reaction which involves clotting factors leading to formation of a stable blood clot to stop bleeding. So intrinsic, extrinsic, common pathways, that's what the part of this cascade. Now, the important drugs who either helpful in plugging that hole, such as patients with hemophilia who lack or deficient in clotting factors, or the drugs which are used to prevent the formation of clots or dissolve a previously formed clot. These are all coagulation modifiers. So different types as on this slide, like anticoagulants. So anticoagulants, the main purpose is to prevent the formation of new clots, right? And as well as stopping an existing clot from growing. Examples such as your heparin, warfarin, just Coumadin, and then the direct oral anticoagulants such as your dapigatran. Then there's rivaroxaban like Xarelto and Pexaban, all those. Then there are antiplatelets. They prevent the platelets from getting together. Platelets are kind of, they are in the blood, they're flowing around, but just think about it. Sometime we are on freeway and we find out the traffic is slowing down. And at one point, you're just curious, like, what's happening? I don't see anything. There's no accident on my side. No fires going on or anything else. But why the traffic is slowing down? And after 30 minutes, you reach a point you see that accident was on the other side. And you're just curious, like, why did you slow down on this side? It happens, right? Because one person saw, oh, what happened there? And now the other person started looking, what happened there? And everybody's looking there, everybody's slowing down, even though it's not on there, right? So now they're causing that clog, right? Everybody's blocked there. Similarly, these platelet, so whenever there's an injury, one platelet goes there. Oh, what happened here? It calls the other one. Hey, do you see something happened here? Come over here. So now they start getting together, forming that clump there. Make sense? This is what these platelets do. And these medication, antiplatelet, it keeps them separate. Hey, keep moving on the freeway. Don't clog here, right? Not affected. Don't slow down the traffic. And that's what the purpose of your antiplatelet drugs. Anybody know any or give an example of antiplatelet? No platelet again? Which one?
Aspirin.
Yeah,
Aspirin.
good job. Aspirin. Aspirin is the topmost. Number 2 is clopidogrel, Plavix. These are the most two, or you say that mostly used. Mostly aspirin, 81 milligram called baby aspirin, but it's not that baby, okay? And don't take it as that light. That baby can cause bleeding as well. And then the drugs such as your thrombolytics. Thrombus, clot. Lytics, which breaks them down. So the drugs which break down the clot, such as the drugs I told you, ART therapy, alteplase, reteplase, tenecteplase. When somebody is experiencing like a stroke, heart attack, to open up, break that clot, these drugs are used. Somebody is experiencing a stroke, heart attack, pulmonary embolism, that's one that's used. Remember the ART, it's called ART therapy. Okay. Then your antifibrinolytics. Now, fibrinolytics, they lysis means break down the fibrin. Antifibrinolytic, which stops that breaking down. So these drugs promote formation of clot. Example, your hemophilia patient, because remember they do not have clotting factors. They are deficient in that, such as your tranexamic acid. Okay, any questions so far? Is everybody clear, comfortable with these concepts?
I had a question.
Yeah, go ahead.
So you said that anticoagulants, they don't have a direct effect on a blood clot that's already been formed. But then you also said something else like prevents a existing blood clot from getting worse. So which one is that one?
We were talking about coagulation modifiers. It was about your anticoagulants, which technically, if you, in simple words, you say that inhibit the formation of new clots, but to some extent, it helps in preventing them to grow further. They do not dissolve them though, but to some extent, they do not let them grow further. Make sense? Okay. Good question. Okay. Anticoagulants. They are against the coagulation process, right? Coagulation makes what or cause what? Formation of clots. So they are against them. So these drugs help prevent the formation of blood clots by inhibiting specific components of the coagulation cascade. Okay. Now, the types of anticoagulants. right? Such as your vitamin K antagonist. Good example, warfarin. Warfarin. It inhibits the synthesis of vitamin K dependent clotting factors, which are factor 2, 7, 9, 10. 2, 7, 9, 10. Then one, or not one actually, more than one. First important thing, remember, clots are high risk, correct? Because they can block supply of oxygenated blood, correct? That is a risk. Now, when you use the drugs to prevent or treat, your patient will be at another risk, which is completely opposite. So rather than clotting, now they'll be at risk of blank, blank, blank.
Bleeding.
Bleeding. So these patients are always risk of bleeding. Okay, now whenever somebody is at high risk, what do? We monitor, correct? So there might be monitoring criteria different. For example, if we are giving warfarin, we need to monitor patients' INR, internationalized normalized ratio. So it has to be between 2 and 3. For therapeutic dose, it should be between 2 to 3. Now, what it means, if it's below 2, means the patient at risk of clotting, because it's not enough. But if it crosses that number 3, anything higher than that puts your patient at risk of completely opposite, which is bleeding. Is it clear? Okay. Now, is it the same criteria, the same test for all kind of anticoagulants? No. We need to know which one belongs to what. And the next thing we'll need to know which antidote is used for what. Because remember, we are handling what? High risk drugs. So we need to be prepared. We need to know what to monitor and what to do in case of there is an indication of too much toxicity. Yes, agree with me?
Yes.
All right, all right. Thank you for being so kind. All right, you guys agree with everything. Thank you. All right, now for warfarin, we are clear what to monitor. Are we clear what to monitor?
Yes.
What are we going to monitor? What is we going to monitor?
INR.
INR. And what is the
PTINR
value?
2 to 3.
2 to 3. Okay. Now let's move on to heparin. Heparin comes unfractioned fractions based on low molecular weight, their structure, and all that. Okay, their efficacy or the frequency. Then there are direct acting, indirect acting. So let's move on one by one. Now heparin. Number one important question, how do they work? How do they work? So if somebody asks you, do they prevent formation of new clot or they help in dissolving an existing clot?
Prevents.
Yeah, good job. That is very important to know, guys, okay? They prevent the formation of new clots, not to dissolve an existing clot, okay? That's important. So they enhance the activity of antithrombin, which is a natural inhibitor of the clotting factor, such as your 10A or 2A, which is thrombin. Okay, and it comes in unfractioned heparin and then low molecular weight heparin, which is your enoxaparin, low enox. That's most common one you're gonna see. Okay, which has like a shorter polysaccharide chain derived from the unfractioned heparin in primarily inhibiting factor 10A. Okay, it has more kind of predictable anticoagulation as compared to the other one. Okay. Now, there is a condition. It's called HIT, heparin-induced thrombocytopenia. So if it's too much of heparin, that condition can happen. Okay. Thrombocytopenia. Penia means less. Thrombocytes go slow. Okay. Patient might be risk of bleeding. Now, what if? Okay, actually, no, not there. So which lab to follow with heparin?
APTT.
Yeah, APTT, good job. Remember that. It's important. APTT, activated partial thromboplastin time, which is used to adjust the dosing as well as monitoring. Now, next question is, what if APT tells you patient is at risk? What is the reversal agent or the antidote for heparin?
Protamine sulfate.
Yeah, so let me give you a tip, guys, okay? Remember me, okay? Or I can say the problem I experienced last week. So I had a HP computer, okay? HP computer. H means heparin, P for protamine. So my HP computer died last week, okay? So if you ever have to think about your reversal agent antidote, so you can just memorize Professor Sraw's HP computer died last week. Okay, that goes together because what's going to happen in a week or two, warfarin reversal agent, heparin reversal agent, all those are going to get mixed up. So don't let them shake hands. Keep them separate. HP, heparin, protamine. Okay. This we already talked about. There are two different types. You don't have to go in detail. Now, once again, heparin, used for prevention, right? And the test is APTT, reversal agent protamine sulfate. Remember, you may see the flushing the catheter with heparin so that they don't get clogged, but the ones used for this purpose, they are in a very low dose. They're very low strength, highly dilute. Okay, sorry, give me one sec, guys. Okay, sorry about that. So because this is a high risk drug, okay, make sure you double check. Involve another nurse. Okay, these high risk drugs, including even insulin, has to be checked by two different nurses. It's very easy to make a mistake, which could be real costly to your patient. They can bleed to death. About like, I would say like 10, 15 years ago, there was an incident somewhere in a pediatric unit in a hospital where somebody accidentally flushed the catheter with a high unit or strength heparin. Luckily, nobody was injured, but there was a very, 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 very high risk thing. It has to be highly diluted in order to flush the catheter as compared to what you're doing to prevent the clot. Okay. So this is how your Lovinox looks like, enoxaparin. This is one of the most common one you will see. For example, somebody just got out from like a hip surgery or knee surgery, right? So that is a very high risk situation for them to develop clots. DVT, very high risk after the surgery. Even after delivering the baby, especially when they had the C-section, any surgical procedure puts your patient at high risk of this clotting. Okay, so make sure that everything is monitored, done properly, and then if they are going to use, sorry, I think I switched the slide. So if they are using this Lovenox, so very commonly you will see patient coming to rehabs, going home after getting discharged after surgeries for only short period of time, not for long, short period of time, given these, and they are given in the same manner how you give insulin, like, in that abdomen area, same way. Very important point, educational point. If you are educating the patient, make sure to tell them, because that's a natural thought that, when you before you try to inject anything, you look at the syringe and you see an air bubble, you try to kind of tap it or kind of expel the air bubble, right? But with this drug, you should never try to expel, because remember, a slight dose you lose can increase the risk of clotting in that patient, and you can lose the dose while you're trying to expel the air bubble. That's not going to do anything bad to your patient. So do not try to expel the air bubble. Very important. It's a basic thing, or very important. People do that. Okay. Now, enoxaparin is a prototypical low molecular weight heparin, means the first one developed in that class. Okay. It has the lower risk of HIT, the heparin-induced thrombocytopenia, as compared to the unfractionated heparin. So that's why it's preferred. And also suitable for outpatient use because it's easy to use. So remember now, in case of toxicity, high risk, the reversal agent or the antidote is protamine. Okay. Now, we know that we're trying to prevent a clot. But while we're trying to do so by giving them a medication, that medication can put them at a different risk, which is risk for bleeding. Right? Then what do you educate the patient to look for? Any signs and symptoms of bleeding, such as blood in urine, called hematuria. Urea is urine. Heme means blood, blood in the urine. Then melena, which is blood in the stool. Petechia, that means that's a skin reaction under the skin, the bleeding under the skin. You will see little tiny pink dots under the skin. It could be all over the body. That's a severe issue. Then bleeding gums, those kind of things are indications. Okay. And this we already talked about, HIT, the heparin-induced thrombocytopenia, where thrombocytes are penia, means thrombocytes are low. And when thrombocytes are low, which are responsible for clotting, now your patient will be at risk of bleeding. Okay, any questions so far, guys? Any question?
No question.
No queries? All right, so if no question, let's move on to another important drug, which falls under the class of coumarin. Warfarin is the one which belongs to that class. Okay, and this is also high-risk drug. Okay, high-risk drug. So it inhibits the vitamin K dependent clotting factor 2, 7, 9, 10. Okay. Now, because we know it's a high-risk drug, high-risk drugs for bleeding in, right? Then what we do, we monitor. How? A test. Which test? PT-INR, or some places you may see just as an INR, international normalized ratio. Normal, majority, you will see between 2 to 3. But as here it says as well, 2 to 3.5. In certain resources you will find 2 to 3.5, but more commonly used is 2 to 3. But just keep that thought open that somewhere between 2 to 3.5, that is normal. Anything below 2, high risk of clotting. Anything beyond 3, that puts your patient at risk of bleeding. Everybody good with that? The number which says 1, INR 1, that is if somebody's not on it, okay? Not on it. And that's what not you're going to handle. You're going to handle patients. You're going to do the labs when somebody's taking it. So you're dealing with a number between 2 to 3. Okay. Next important point. You may come across patients who are being discharged from hospitals, say they experience a stroke or a heart attack. Okay. Now they were given IV drugs or any procedure, any condition which puts them at risk of clotting. Now, naturally, when somebody's at risk of clotting, in order to reduce that risk in future, keeping patients safe, we're going to give them something which prevents the formation of clots, right? That would be our approach. So say that we need to put patient on warfarin, right? So if we pick up warfarin, but the patient was given, suppose that injectable drug, right? Such as heparin in the hospital. Now, when they are getting discharged, you're educating the patient, okay, you're going home, here your heparin, so this is what you're going to use, and this is what the doctor wrote a new prescription for, that is warfarin, and you're going to start that as well. And the patient, as of spent 15 minutes before they came to you for the discharge, they had a few minutes downtime, looked into it on Google, right? So you're full of that first 5-6 lines of knowledge, right? Which showed up on the Google, which says that it increases the risk of bleeding. The patient saying, hey, look, heparin and this warfarin for same purpose. Well, why are you giving me both? And I know it increases the risk of bleeding. It should be one or other. Why are you giving me both? Correct? Is that a genuine question? Yes. But do you think is that a mistake or is that okay? Any thoughts?
Warfarin takes longer to take effect.
Oh my goodness. Very good, Jennifer. Excellent. All right. Because they are at high risk of clotting, we need to keep them safe while warfarin builds up in their system, which will take few days, usually around 5-6 days. So we need to keep the patient safe during that period. So that's the transitional phase when both drugs are used, overlapped, and once it's at 5-6 days, we check the INR between 2 to 3, and then we discontinue heparin. Everybody understood? Clear? Any question on that? Oh, okay. That is a very important point because you will see these patients, especially if you can work on a hospital, any surgical units, discharging patients or receiving patients at rehab, very common thing to see. And patient, if you don't know, patient is gonna show like, I know what I'm saying. It looks like you don't know what you guys doing. You're putting me at risk. So know these things. All right. Warfarin. As we know, we're trying to prevent a problem, formation of a clot, which can cause these issues, such as I told you earlier, if you're moving thrombus, the clot, which is called embolus, decides to travel, explore all the horizon in patient body, right? Deep down in the legs can cause DVT, deep vein thrombosis. Going towards the lungs can cause pulmonary embolism. And if fell towards the heart can cause MI, myocardial infarction, or in simple meaning called heart attack, or travel towards the brain. And wherever it gets stuck, it blocks the supply of oxygenated blood further down. And whatever the part further down is deficient in oxygen, it starts dying. And when some die, they tell the other, I am dying, and they are sad. Now they start dying, called necrosis, death of cells, and you cannot reverse it. So that is the reason it requires immediate intervention to open up, restore the blood supply. Okay. All right. Now, what if your patient is experiencing toxicity? Well, the first thing is do not hurt them more, correct? Stop, hold it. And based on your assessment evaluation, then they may need a reversal agent, which is your vitamin K, correct? Vitamin K, that's a reversal agent. And in some patients at risk of high bleeding or who are bleeding, they may need certain replacement factors, such as your prothrombin complex concentrate or your FFP, the fresh frozen plasma, for rapid reversal, those emergency situation. Okay, this is just a basic thing. You don't have to remember it, but just wanted to share with you that if they're overdosed. Now, if the INR is below 5 and there's no significant bleeding, then what you can do is monitor the patient while you decrease the dose. And then adjust the dose and keep the dose or continue the dose when it is between that 2 and 3 INR value. If INR between 5 and 9, even though there's no bleeding, hold the dose and continue at a lower dose when it's between 2 and 3. Okay? But if INR is over 9, doesn't matter they're bleeding or they're not bleeding, discontinue. Give them fresh frozen plasma and resume at a lower dose when their INR is between 2 to 3. And if they experience severe bleeding, forget about everything, discontinue, give them fresh frozen plasma, look for an alternate, do not continue warfarin. Next, here are your factor 10A inhibitors. They specifically inhibit factor 10A, which is an enzyme crucial for conversion of prothrombin to thrombin in the coagulation cascade. Once you block the factor 10A, then these drugs very effectively can prevent the formation of fibrin clots. And these drugs can be used to prevent and treat different type of thromboembolic conditions when they have the clots. So this can be used for prophylaxis to prevent as well as treatment for these conditions such as DVT, deep vein thrombosis, or pulmonary embolism when it's in lungs. Once again, these drugs prevent or treat clotting. So the most common concern is bleeding. Okay. And always make sure you monitor that if there are multiple drugs with the same action, that can increase the risk of bleeding. Okay, this is an oral agent, Xarelto, rivaroxaban. Then there's Paxaban, there's Edoxaban, Batrixaban. Then there's Erixtra, Fondaparinux, which is a sub-Q injection. So these drugs are used in prevention of clots, such as with stroke patients, with AFib, or after surgery. And very commonly, as I said, in your orthopedic surgeries. And out of those, most common, your hip and knee surgeries. Okay. And usually, majority they don't need like regular monitoring like how you need in warfarin. Then direct acting, your thrombin inhibitors, DTIs. So they directly inhibit factor 2A thrombin. Okay. Your examples, Redexa is very common, dabigatran, and the second I would say argatroban. Okay, well, this is the most common, dabigatran, Redexa. And this argatroban, this is an injectable. Important to know about, used in patients with heparin-induced thrombocytopenia and percutaneous coronary intervention when, for example, somebody is suspected with like, a blockage, they say there's a clot, and percutaneous coronary intervention when they go through, either from here or they go down near the the hip. So they put a camera in there, okay, and then they look into that where the blockage is, and along with that there is a little tiny instrument which can kind of, it's like those clippers sort of thing what you can use, and it can kind of has multiple arms, and it can kind of hold and pull the clog out. And also, if they see that a collapsed vessel, or you can say the narrow passage there. We heard about those placing the stents, right? The stents. So that's what they do. They look into that. If removed, they can remove, and then they can place a stent, and then they pull it up. And in those sort of situations, you may see this drug given in the cath labs. And One of the drugs that cause cath flow as well, based on that. Pradaxa is a very common drug used, Pradaxa, dabigatran. Now this drug important is that it's a pro drug. What it means is that it is in an inactive form when it's outside the body. Once you take it, it gets converted by liver into its active form. So important to know, is the patient's liver healthy, fully functional or not? Because if it's not fully functional, it won't be able to convert into the active form, and the patient may not experience therapeutic effect. They will have high risk of clotting. Make sense? Any question?
No questions.
No question? Okay. Do you guys want to take a break? Because we have slides yet, quite a few to complete this chapter. If you guys are overwhelmed, then maybe it'd be a better idea to take a quick break. Yeah. Okay. So it's 11:18. So let's take 12 minutes. So 11 30, right? Okay. I'll see you soon.
Thank you.
Thank you, guys. Yeah, welcome back, everyone. Yeah, please turn on your cameras. Excuse me. Yeah, some cameras still showing off. Ishan, Nico, Angie, Soren, Stephanie, Samantha. Please turn your cameras on. Alrighty. Ready to move on? Yes. Yes. All right.
We're ready. Our brains are just full because we're studying for Friday.
I know, I understand. It's challenging. But remember one thing always in life. If you're not feeling challenged, means you're not moving forward. If you are challenged, you're on the right direction. Okay. You have to achieve bigger goals requires more sacrifice. It's always gonna be challenging, but always rewarding. You will forget about all the torture experience here, right? Whatever, how much I'm bothering you, all that crappy stuff, right? All these drugs from your left side, right side, top, everywhere. And
We
you're
just
probably
we,
sleeping with drugs. I'm sorry, what was that?
we just have to remember to say hello to pharmacology. That's all.
Yes, yes, yes. You have to develop that friendly bond, continuous touch, right? But this is one thing is gonna make you different from other nurses. Remember that I told you super nurse. It's not easy. Everybody can't be a super nurse. But once you are, people will respect you. They will see you from far, far away who knows what they're doing. I've seen people from years and years not comfortable with drugs. Yes, they passed, they got the license. That's not the only thing you need. You need knowledge. And knowledge needs much more. I would say your dedication, focus, efforts, and you're always gonna feel short, running behind. So stay organized all the time. Put things, park them at the right place so that you can find them whenever you need them. And we try to memorize drugs, just random, it doesn't work. So make sure, please, that you are developing your study guide. Okay, all right. Pradaxa, dabigatran, as I said, is a prodrug, requires healthy liver. And biggest concern, once again, we're trying to prevent clotting. The biggest risk comes along. Will be bleeding. Okay, what if patient experiencing toxicity? Well, we need a reversal agent. Anybody knows? What is an antidote for Pradaxa?
Praxbind?
Yes, Praxbind or generic edarucizumab. They're MAB. Okay, Praxbind, important drug. Okay, please know that. The reason Pradaxa is a common drug. You will see that a lot. So we need to know how to manage it. Rexpine or adalimumab. That is an antidote for Pradaxa. Okay. Indications, well, we're talking about any condition associated with clotting risk. It could be myocardial infarction, which we call heart attack, unstable angina, AFib, all those. Or somebody has indwelling devices such as heart valves. Or very commonly, orthopedic surgeries. Okay, contraindications. Who should not take them? Well, who are already at high risk. Number one, pregnancy, no, 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 and no. Okay. Not in pregnancy. And also anybody who has indwelling epidural catheter. Not the regular catheter we're talking about, it's epidural catheter. Shouldn't be using those. As hematoma. Now the problems comes here is bleeding. One of the biggest concern is bleeding, bleeding, and bleeding. So you should be aware about and educate your patient about signs and symptoms of bleeding. Anybody remember what are the signs and symptoms of bleeding?
One was like the pink dots under your skin, like blood under your skin.
Petechia.
Hematuria.
Yeah, hematuria, which is blood in the urine.
Melina.
Blood in the
Melina.
stool.
Yes, blood in the stool. Good job. And very commonly, bleeding gums. Interactions means what things, either food, drinks, or drugs, what else can put them at risk? Well, the patient taking these drugs are at high risk of bleeding. So anything taken together which puts them at increased risk of bleeding, that's a possible interaction. So we need to look, or another way to look at it is if we're giving this drug to prevent a clot, and if any either food or drug, whatever, can reduce the effect of this drug, can put them at a high risk of clotting as well, right? So it's two ways. Now, important class of drug, antiplatelet. First thing to know what they are. These medications are used to reduce the ability of platelets to aggregate, stick together, and form clot. You want to keep them spread out, right? Example, most common, aspirin. Aspirin. And number two is your clopidogrel, Plavix. Aspirin usually given 81 milligram, baby aspirin alcohol, right? 1 POQD. Clopidogrel, this is 75 milligram POQD. And then there's few more, Prasugrel, which is Effient. This is injectable. Then this, but these are more important. Aspirin, clopidogrel, Prasugrel, Abciximab, they're more common. Okay, now why do we use them? For patients who are at risk of clot formation in order to prevent that, right? Prevention of myocardial infarctions, heart attacks, strokes. To prevent that, we give them. Somebody had a stent put in, and to prevent the stent thrombosis, usually combination therapy can be used for a while, aspirin and clopidogrel together. Now, biggest concern would be bleeding, bleeding, bleeding. Another thing with these PO drugs is they can upset the stomach, GI irritation with these drugs as well. And you can reduce, minimize that, educate them, take it with food. That'll resolve the issue most likely. So aspirin, most common. What are the important things for us to know? Number one, it is for prevention, right? Preventing clot formation. Number two, suppose as this drug, aspirin, 81 milligram, say it is an enteric-coated EC. Now, important to educate, tell your patient do not crush or chew. And if they ask why, there are multiple reasons, okay? Or you can say the severity of the symptoms can vary, such as minor, maybe GI upset, right? Abdominal cramping, nausea, bloating, vomiting, that can happen. 2, serious adverse effects such as bleeding. So starts with minor, usually minor, the abdominal issues. So if you crush, chew these things, that's what most commonly going to happen. But it can cause too much as well, risk of bleeding, correct? Next, when you're giving them this medication, tell them to drink enough water. Once again, we know that it can upset the GI system. It will reduce that, the GI symptoms. 6 to 8 ounces of water. And as I mentioned earlier, you can educate them to take it with food. That will also reduce the GI symptom. Educate them. Even though it is only 81 milligram, you may consider it as just a baby aspirin, but this baby can cause bleeding as well. Okay. If they ask, how does it work? Well, it's a COX inhibitor, cyclooxygenase inhibitor, COX-1 inhibitor, which leads to decreased production of thromboxane A2, which is a chemical who promotes platelet aggregation. And that's what we are trying to prevent. We're not letting the platelets get together. Okay, any question about this? Everybody is clear, crystal clear about aspirin. I need to add one more thing. Okay, yes, Ella, good. Reye syndrome is a high-risk condition with patients, usually kids, okay? Usually kids. If they're experiencing a flu-like symptom, do not give them aspirin because they can experience which condition? Reye syndrome, which is a severe condition, put them at high risk. So that is very important to know as well. Moving to the next one, which is your clopidogrel. This is number 2. After aspirin, this is the most commonly used. One strength, 75 milligram, POQD. Okay, quite stable. Then there are prasugrel and all ticagrelor, which is Brilinta. They are under the class of P2Y12 inhibitors. P2Y12. Okay. Then your atipibatide, which is your integralin, on the right top, injectable. This blocks the glycoproteins, the 2B and 3A receptors present on platelet, which is pretty much the final pathway for platelet aggregation and preventing fibrinogen binding and platelet cross-linking. So primarily used in acute settings, okay, in hospitals. Emergency situations, as I said, in a PCI, percutaneous coronary interventions to prevent immediate clot formation. When there's an invasive procedure they're doing, they're placing a stent or looking inside, that's a high risk thing, and it can be used at that time. And then there's other drugs, tirofiban, napizimab. Okay, now let's talk about thrombolytics. Now, thrombus is a clot, lytics which breaks down. So drugs which breaks down a clot. Now, are they used for prevention or treatment? What does
Treatment.
the name say? Treatment.
Treatment.
Because you can only break something which is already formed, right? The thrombolytics, breakdown, dissolve, previously formed, clot. And they are mostly used in emergency, like somebody experiencing a stroke, somebody experiencing a heart attack. You need to restore the blood supply quick to prevent any damage. And this is the one I was talking earlier called ART therapy. Okay, ART means A for altiplase, R for retiplase, T for tenecteplase. It's not they're used all together, it's one or another. So these are three most commonly used. And if you see one of them, it says cath flow because they are used in the cath labs, cardiac labs. Okay, they convert the plasminogen into plasmin, the enzyme which eats up, digests the fibrin, the clot. So it breaks down the clot. And once again, used in acute conditions, like somebody experiencing myocardial infarction, they're experiencing DVT, deep vein thrombolysis, pulmonary embolism, acute ischemic stroke. Technically, you need to break that down and restore the blood supply. Okay, what is the biggest concern? Once again, bleeding, bleeding, and bleed. Bleeding is the biggest risk. Either it's internal, superficial, intracranial, could be anywhere. That is basic but important to know. Okay. This is your altiplase, the cath flow, which is the TPA. It's got recombinant tissue plasminogen activator, used in acute condition, as I mentioned earlier, usually within they say like about 4.5 hours or so from the onset. Okay, acute heart attack, which is happening now. And when PCI is not available, the percutaneous coronary intervention, when they can go in and take that out, it cross that time frame. So can use that. Retiplase, tenecteplase falls in the same class. Okay, antifibrinolytic. We talked about fibrinolytic, which breaks down the fibrin, the clot. They are antifibrinolytic. They block the action of breaking down the clot, means they promote clot formation, such as patients who do not have clotting factor, as in case of hemophilia patient, right? So they inhibit plasminogen activation, preventing the formation of plasmin, an enzyme which breaks down the fibrin clot. So it blocks that pathway. Commonly used in hemophilia patient on valvular brands. It's technically they do not have enough sufficient clotting factors and they can bleed. Most common adverse effect, GI, or the worst case scenario, I mean, giving too much, thrombosis risk, nothing more than that. Then there's amniocaproic, another one similar to tranexamic, prevents the activation of plasminogen and inhibit the fibrinolysis. Very commonly used post-operative bleeding. Somebody had like a dental or cardiac surgery, or somebody such as hemophilia, the bleeding disorders. And then another drug is a desmopressin. It's used for various purposes. It's here because it's also used in hemophilia, but this drug is also commonly used in another hormonal disease, diabetes. Remember, this is not diabetes mellitus. It's not blood sugar. It's a hormonal condition, diabetes insipidus. Okay, diabetes insipidus. And then this drug, the nasal form in the middle, this is also used for nocturnal enuresis, the kids, when they pee in the bed at nighttime bedwetting kids, the nasal formulation can be used for that purpose as well. Okay. This is tranexamic acid. Same thing, inhibits the binding of plasminogen to fibrin and preventing the fibrinolysis. Same way how previously we're looking at surgical procedures to reduce the blood loss during major surgeries like cardiac, orthopedic surgeries. Nursing implication. What is important when you are giving these medications to your patient? Get detailed assessment, because that can put your patient at risk if you miss something. Medication history, underlying conditions, what else they're taking, what their diet looks like, any OTC, herbal, supplements, everything. There are many herbal OTC products which can either put them at risk of clotting or bleeding. Contraindication, any underlying cause which can put them at risk, make sure you know it. Set a baseline of vital signs for you to compare. Similarly, lab values, so that you know that what difference it's making. Now, excuse me. One thing I wanted to mention, actually a couple, not one. Number one, suppose patient had bleeding and you have to give them like fresh frozen plasma or the RBCs, you have to infuse. There's a critical step important for you as an RN to follow. Remember steps that when you can delegate things to others, right? To LVNs or else, you can delegate certain things and certain you cannot. So here, even though you can delegate, but not until certain time. Example, if you're giving them a blood product like RBCs, you're infusing them, it's your responsibility to stay with them for the first 15 to 30 minutes with the patient, or until you take the first set of vital signs after the infusion. Got that? That is very important. Make sure you don't delegate it. Once you do that, then you can do it. Okay? Because sometimes you think, yeah, vital signs can be delegated. Not until you take the first set of vital signs after you start the infusion. Another thing, when we're talking about heparin, now you may see products that they're pre-filled. What if you have to fill them, and you got to choose the needle? There's a specific things which you need to remember. So please note that down. The needle size you need for heparin injection, you need the needle 1/2 to 5/8 inch, 1/2 to 5/8 inch, and 25 to 27 gauge. Got it? 1/2 to 5/8 inch and 25 to 27 gauge. That's what you need to know about when you're selecting a needle size for heparin. Everybody got that? Or you want me to repeat it? Everyone got it?
Got it. 1/2 to 5/8 inch and 25 to 27 gauge needle.
1/2 to 5/8 inch and 25 to 27 gauge. And once again, tell them, do not aspirate heparin injections. Can cause hematoma, very important, okay? And then monitoring is essential. That is crucial part, because your patient is at risk of bleeding. And we need to know which one belongs to what. Okay. APTT for what? What do we, is it for heparin, warfarin? What do we monitor for? For heparin, right? And what is an antidote? Protamine, right? Educate them, rotate the injection site. Rotate the injection site, and usually heparin, it's given in the abdomen area where you give your insulin, same way. Okay, now for warfarin, you need to monitor the PT-INR. Now, what was the normal INR, guys?
2 to
2 to
3.
3.
2 to 3, and an antidote, vitamin K.
Vitamin K.
Right? Vitamin K. And when they are taking warfarin, make sure they do not alter their diet, especially green leafy vegetables may contain vitamin K. Do not vary it because that can vary their INR. Okay. Now there are many herbal products which can alter the response of those drugs, can put the patients at risk of bleeding. Remember these G's, okay? They're like G's, they call their high risk. Ginger, garlic, ginkgo, those are important. And then your peppers, capsicum peppers, feverfew, ginkgo, St. John's wort, ginseng. So they have potential interaction with these blood thinner products. Okay. Always educate them, monitor any signs and symptoms of bleeding, and also perform regular follow-ups with labs. Okay. Always educate them, do not get hurt. It could be even just hitting the walls or sofa or something, even that they can easily bruise and bleed. Also, it's very helpful if they wear a medical alert bracelet or something, in the neck, something where, suppose if they got involved in automobile accident, they're bleeding. Who knows, like who's at less risk, more risk, no risk. If they have a warning there, that alert bracelet, people know this person is high risk. We need to intervene quickly. And what type of action needed? Right? Okay, I think that's pretty much it. I am going to, okay, let's do a couple of questions quick, and then we're gonna start the next chapter. Good job, good job. D is the correct choice. Very well, very well. Okay, next. Perfect. D. Okay, D is the correct one. Okay, next. Okay, so here I see majority you're answering C, okay? Remember, this you need to know which drug belongs to what class, like antiplatelet or thrombolytic or this or that. So the correct answer is B. Remember, antiplatelet. Stick a label of most common drugs with each class so that you can correlate it. Antiplatelet. Stick aspirin. And what goes along with aspirin? Remember, number 2, I told you clopidogrel. So B is the correct choice. Always know the top 3, couple 2-3 drugs at least in that class. And that's what most of the time they test you on. Because your enoxaparin, your heparin, these are anticoagulants, and altiplase is a thrombolytic drug. Antiplatelet, which inhibits platelet aggregation, that is aspirin and your clopidogrel. Okay. Perfect. Good job, guys. Proud of you. Very well. 2 to 3 is the normal, and 2.5 is within that range. So it's perfecto. Right. Good job. Okay. Any other questions you guys have from this chapter? Anything doubtful? Everybody okay? So as you noticed in the question, even though you understood the concept, but sometimes you find it hard to figure that out, which one belongs to what. So categorize them. And remember, top 2-3 drugs, and you have a higher chance of getting them right. Okay. Any question before we start the last chapter?
Quick question, Professor. How many approximately question will be related to drugs on the exam?
The total number is 60, but I don't remember which chapter, how many individually.
And then like how many medication that we study will be on that test?
Okay, look, I don't know the number exactly, but as I said, 70-75% material or what we cover that you see from out of that. It's not that something with the name of the drug or anything, but from this material you will see very high number of questions there. But it just, I wish we had kind of have longer hours, like a 7-8 hours day for going over all the drugs and all the information. That is ideal to learn, but unfortunately, the number of hours, restricted hours, doesn't allow me to go over everything. And one thing I want to say that you guys are lucky here that you got 1 extra hour, your batch and another cohort I'm teaching right now, Fremont. Both I was able to convince everybody to do it 4 hour. Everybody else, they had 3-hour lecture. It becomes so fast, and then that means I have to squeeze more. I have to cut the lecture material I could cover. But it's good that we have 4 hours, and we can at least go a little bit more. Okay, anything else, guys, or are we good to move on next chapter? No questions?
No questions. Next chapter.
I do have one more
Oh,
question.
yeah.
Would you be able to create, like, moving forward? I know you probably can't do it for this week because you're really busy, but like a practice quiz or a practice test that would prepare us for the Friday exams, maybe on like Evolve or something like that?
Yeah, and this week I don't have time. I wish I had, but not this week. I'll try to figure out something next week.
Yeah, just so that we can like pre-test ourselves so that we can get a gauge on what we need to study and what we kind of know.
Yeah, I'll work on something hopefully next week.
Okay, thank you.
Okay. And as I said earlier as well, I'm going to try to work on more of your calculations as well, so that I can give you more questions to practice, and you can kind of improve, learn better from that. Okay, anti-lipemic drugs. So these are your hyperlipidemia, when your patient has high cholesterol. So we'll talk about that, how these drugs work, any interactions, adverse effect, toxicities, and important aspects when you are taking care of your patients who are on these medications. So first of all, let's know the problem. As we always start, we'll talk about solution later on. Hyperlipidemia. Hyper means high, lipids, the cholesterol, high cholesterol, which is the fatty substance, right? Elevated levels of lipids means fat in the blood. Primarily two culprits, cholesterol and triglyceride. Cholesterol, triglyceride. And why they're risky? Because they increase the risk of atherosclerosis, means development of cardiovascular disease, such as your CAD, coronary artery disease, or heart attack, stroke. Okay. Now, there are different types, such as hypercholesterolemia, means elevated LDL levels. Now, one thing here to understand, you may find a little confusion here. LDL and HDL. LDL is low density lipoprotein, HDL is high density lipoprotein. And when we talk about, oh, high fats causes this, and you may point towards HDL as the bad guy. It's opposite. HDL means happy. That's a happy, good cholesterol, HDL. You want it high. LDL, which is low density lipoprotein, is the bad guy. You want to keep it low. Is that clear to everyone? Okay, then the second condition is hypertriglyceridemia, means high triglyceride. They're very, very high risk. Then mixed hyperlipidemia means they may have both LDL as well as triglyceride levels high, even much high risk. Okay, and based on the cause, such as genetic, called primary or familial hyperlipidemia, that's because of genetic factors. Then secondary, which is more common because of lifestyle, what they eat, any underlying conditions, or their activity, all those things. Okay, so as I just said, two culprits, triglyceride and cholesterol. Now, function of triglyceride is that is used by the body for energy storage. It's not that we don't need it. We need it. When you eat, the body converts excess calories into triglyceride, which are stored in the fat cells and used for energy between meals. So the elevated triglycerides are associated with an increased risk of pancreatitis and may contribute to cardiovascular conditions. And your cholesterol is essential for building cell membranes, producing hormones, synthesizing vitamin D. So it's important, but excess. Okay, first is managing them with lifestyle modification, diet, what they put in, and increasing physical activity, smoking cessation, stopping alcohol, and losing weight. But if it doesn't work, well, that's when you have to, we covered this thing. So that's when you have to start the medication. So once again, Lipoproteins means your lipids or this LDL, HDL, whatever they are. So LDL, low density, they are the bad guys. HDL are the happy ones. That's what we want. High. Once again, HDL, happy, good one. LDL, bad guy. We want the bad guy low, below 100. We want the HDL happy guy higher than 40. And total cholesterol below 200. Okay. Everybody know the numbers? Yes. Total below 200. LDL, bad guy below 100. Good guy above 40. Okay. Now the problem. Atherosclerotic plate formation. So this is the process where fatty deposits build up inside the walls of arteries, which makes them more narrow and stiff. They don't stay more flexible. Okay, and which increases the risk of cardiovascular condition. Now, here I want to show again. So arteries, when they become hard, okay, and they become tight inside, so buildup of fats, cholesterol, other substances, your artery walls. That substance, the buildup, it's called plaque. And that plaque can cause your arteries to become narrow. Remember these arteries, they supply blood, right? Blood flows through them. It's like the pipe and something is clogging it, making it tight. Well, the blood is not going to flow freely, right? And this plaque can burst and release a clot. And that clot can stuck anywhere else and inhibit or disrupt the supply of blood to whatever the area farther down and causing the issues such as myocardial infarction, stroke, those kind of things. Okay, now some terms written here are such as your atherosclerosis, generalized specific type of arteriosclerosis, and which is the buildup of fat in the artery walls. On the other hand, your arteriosclerosis, when the blood vessels which carry oxygen and nutrients from your heart to rest of the body, they become thick and stiff. That is called your arteriosclerosis. Okay? They're related, but they have different meanings. Once again, arteriosclerosis, general term for thickening, hardening, loss of elasticity of the arterial walls. It can affect all type of arteries. And atherosclerosis is a specific type of arteriosclerosis, which is thickening, hardening, but so because of buildup of fatty deposit, which is called plaque, inside the arteries. Okay. So this is if the normal artery, there shouldn't be this plaque. Plaque makes it narrow, disrupting the flow, and when it explodes, then it can release the clot, and that clot itself can cause another problem. There's another view. Look at that plaque and see how it narrows down the arteries and disrupting the blood supply. Everybody understand what is plaque, how it impacts your patient, what type of risk they're associated. Any questions so far? No? All good? This is, we already looked into, that wasn't just the numbers. Now, coronary artery disease, because of these problems, can develop into coronary artery disease caused by, as I just said, the plaque buildup in the walls of arteries that supply blood to the heart. That's why we call it as coronary arteries, and the problem is called coronary artery disease. Okay, then there's vasculitis, which involves inflammation of the blood vessels. And that inflammation can cause the wall of blood vessels to thicken and reduce the width of that passage through the vessel. and then the blood flow is restricted, which can result in organ and tissue damage. Then another condition, Kawasaki disease, it's also causes inflammation, swelling, redness in the blood vessels, and it's more spread out in the body, throughout the body. Okay, usually affect younger kids, younger than 5 years old. Condition polyarteritis nodosa. This is a rare condition where multi-system disorder, widespread inflammation, weakening, damage to small, medium-sized arteries. It could be any organ. Maybe supplying blood to the kidneys, to heart, nervous system. All those can be affected. And then vasospasm. It is the narrowing of arteries caused by persistent contraction of the blood vessels called vasoconstriction. Because the narrowing of those vessels will reduce the blood flow and can impact other parts such as your brain and coronary arteries and all that. Now, the drugs we use, they're called anti-lipemic for hyperlipidemia to bring the high cholesterol down. What is the drug of choice for high cholesterol?
Statins.
Yeah. Anybody knows? Other than statins, what else they called? More technology, not technology, I'm sorry, more medical terminology.
Anti-hyperlipidemics.
No, they're called HMG-CoA reductase inhibitors. Okay, so when non-pharmacological intervention doesn't bring the desired results for 6 months, or the patient has a high risk, we tell them, hey, make lifestyle changes, stop smoking, lose weight, stay active, don't drink alcohol, all that doesn't work. We bring in statins. That is more generic term, but for healthcare professional, it's called HMG-CoA reductase inhibitors because they inhibit HMG-CoA, which is an enzyme, which causes production of, or responsible for production of cholesterol. Now, how do you identify them? They end in statin. That's why we call them statin. Simvastatin, torvastatin, rosuvastatin. That's why they're named as statin, because they end with statin. Then there are other drugs as well, like bile acid sequestrant, vitamin B3, niacin, but in much higher doses. Then fibric acid derivatives like fenofibrates and stuff. Then Zetia, which is a very effective drug, usually given along with statins, which is an absorption inhibitor and combination drug, such as Vytorin, which is a combination of a statin and Zetia. Okay, so let's go over stuff. Here are some new drugs, such as PCSK9 inhibitors, very effective, like Praluent and Repatha. They're MABs, Lirocumab, Evolocumab. These are newer ones, very effective when you need quick, more effective, you need higher compliance because they are once a week. Okay, and a lot of patients taking statins, they complain about myopathy, that muscle pain, like leg cramps and all that, and these drugs doesn't cause that. Okay, so first of all, statins. So they low cholesterol, LDL, and reduce the cardiovascular disease risk, your heart attack, stroke, by inhibiting an enzyme, HMG-CoA reductase, which is involved in production of cholesterol in the liver. Okay. Now, based on patients' age, risk factors, you can start different type of drugs, and identifying statin, they end with statin. Once again, mechanism of action. They inhibit an enzyme, HMG-CoA reductase, which is responsible for cholesterol synthesis where? In the liver. Okay. This is nothing, just in a picture, what we talked about. And as we talked earlier, this is the drug of choice. Now, important. Your patient may come and say, hey, you know what? I don't know if this is working or not working. How long does it take for this to work? Well, this is not Tylenol, ibuprofen, right? This works in different way. It takes at least 6 to 8 weeks for this drug to produce any kind of therapeutic effect. Make sure you educate your patient about that. Okay. Now, adverse effect, very important. Patient may experience headache, but am I worried about it? No. Then what is important, which has high risk? That is what I'm worried about. It's myopathy, muscle pain. What it can indicate to why I'm worried about it, because it can point towards a bigger problem called rhabdomyolysis, which is muscle breakdown. Okay. So if your patient is experiencing unexplained, no reasonable or any cause, they didn't lift anything, they didn't do anything crazy, but they're saying I'm experiencing muscle pain. Well, check their profile. If they're taking statin, could be that. And it's a very high risk condition, rhabdomyolysis. If you don't catch it early, well, that muscle protein will get mixed into urine. Kidneys may not be able to pass it, and they may have acute kidney failure. They may end up going on dialysis. Very, I would say, a common sign, their urine will be dark color urine, and unexplained muscle pain. So please make sure you educate your patient to monitor that. Okay. And liver is involved here, in production of cholesterol and metabolizing the drug. With these drugs, always monitor liver functions. Always. When you're sending them for labs, send order for liver functions as well. So as I said, rhabdomyolysis. So that's a muscle breakdown, usually shows up in the urine as dark color, and it will mess up patients' kidneys. Okay, very important one. So do not miss that one. With statins, rhabdomyolysis, muscle pain, very important. Now, what happens here? A few terms here, such as myoglobinuria. Myo, that is the muscle protein going to the urine. Muscle protein, myoglobin. So that can cause acute renal failure. What you should be doing, stop further damage, further injury. Do not give them statins. Don't give the next dose. Stop it. Okay. Now, very important interactions with your HMG-CoA reductase inhibitors or statins. Grapefruit juice. Do not mix it. Okay. It can cause severe toxicity, such as rhabdomyolysis. Now, this is an example, your atorvastatin, simvastatin. On the next slide, I'll show you one of the most common one used. Which class? HMG-CoA reductase inhibitors. What we use for hyperlipidemia, right? So once again, side effects, watch for muscle pain, myalgia or rhabdomyolysis, right? That's what we are worried about. Usually once a day. And it says evening meal or bedtime. Why at bedtime? Anybody knows why we give them at night? Because your body
Cholesterol is synthesized in the evening.
at night. Yeah, it is synthesized at night. That's why you give it at nighttime. Okay, everybody understand that part? That why do we give it at night? So the patient saying, oh, whatever the hey nurse, whatever the drug you gave, it's not working. Or what? Are you compliant? When do you take? That makes a huge difference. Okay. Simvastatin is another one. So atorvastatin, simvastatin most commonly used, same concerns. Nothing individually what you need to focus on. Now, another class, bile acid sequestrant. Let's talk about what's important about it. Number one is, for example, cholestyramine is one of the most common ones. Cholestyramine. Now, it also comes in powder form. So important in that powder formulation is mix it in 6 to 8 ounces of water. Do not just drop in your mouth and try to drink the water. No, mix it well in the water. And after drinking, if you see residue on the bottom of your cup, mix more water, drink it. Enough water with that is important. Okay. Now, if somebody asks you, how does it work? As it's a bile acid sequestrant, something to do with bile acid. So they bind to bile acid in the gut, preventing them from being reabsorbed. Well, how it impacts cholesterol? Well, what it does is to compensate that loss of bile acid, which were bound, thrown out from the body, from the gut, the liver converts more cholesterol into bile acid, reducing the cholesterol level. So cholestyramine, 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 which is well called right here. These are the most common and once again important powder form. Make sure you mix with enough water. Another thing I want to add here. This is not the first line. This is the second line. But do not give with any other medication at the same time. They can alter the absorption of other drugs, and because they alter the absorption, so when somebody ate food, that's where you get the nutrients, vitamins, all those as well. So if your patient is taking this, most likely they will be deficient in vitamin A, D, E, and K. Vitamin A, D, E, and K, those are fat soluble vitamins. And how you can address that? By supplementing those vitamin A, D, E, K from outside. Everybody understood that? What is important? Any question?
No,
Okay.
thank you, Professor.
All right. Once again, mechanism of action. It is resin absorbed combined with the bile acid in the intestine, form an insoluble complex, and then gets excreted in the feces. Now, they need cholesterol to convert it into bile acid, dropping the cholesterol level. Okay. Okay. Now these drugs, or not, I mean bile acid sequestrant, especially your powder form, can cause constipation. So tell your patient that, hey, first mix it with enough water, and on top of that, consume more fiber with enough fluids. Because if it's only fiber and they don't consume enough fluid, it will make them more constipated. Okay. And as I said, do not give it along with any other drugs. Separate them out, and your patient may need supplementation of vitamin A, D, E, and K. And this is how your cholesterol looks like. Okay. Once again, mechanism of action: absorb, bind with bile acid, insoluble complex, goes out in the feces, Okay. Niacin, vitamin B3, but in higher dose. In higher dose, it reduces the production of LDL and triglyceride in liver and suppressing the production and reducing the cholesterol level. Now, important, when you give, because it goes in a higher dose for this indication,